Okay, thank you, Dr. David. So we're going to take two systems and put them through the paces. One is the new Arcadia balloon by Merit, and then after that we'll take a look at spine jack made by Stryker. And so we will access L5 here. So we're starting off with the Arcadia system, and we'll come down effectively starting at about 9 o'clock. And I'm going to access L5 here, so we're going to use a big balloon. All right, and let's go lateral. I'm going to try to get a 30 millimeter balloon, which is a large volume balloon that holds 8 cc's of contrast. Come down a little bit. There we go. So I really like the look of that. So we're just inside, I'm going to turn the bevel around, advance it in, and we will switch from the access needle. Let's do a little poor man's wig wag, see if sharpen it up. Nice. Okay. So interstylite comes out. Power curve goes in. And this is beveled, so it steers opposite. This is beveled, and it steers opposite the bevel. So whenever the power curve is actuated, it steers the direction away from the face of the bevel, so it exaggerates the natural steering capability of the distal tip of the needle. And all of the indicators are proximal. And the direction is indicated by this small rubber arrow, so you can see where it's going. And so the direction here, with the approach at 9 o'clock, it's going to be directly across. So I'm going to put it directly across here, and we'll place it in the posterior portion of the vertebral body, like so. And I'm going to push it in, and as I do so, we'll get it about halfway across the vertebral body, and we will start to make the turn. And you'll see as we advance forward that this thing will start to foreshorten. And I'm going to hammer the whole thing in, as we're a little bit short.
Turn off the video. I was on video all this time. I'm like, oh my God.
All right, good. Shoot that. Yeah. And let's come back around AP. You can see that foreshortening upon itself. All that is the power curve curving to the opposite side of the vertebral body. The orientation of the Arcadia balloon is very medial lateral. And so we're directly across. In fact, we're all the way across to the opposite pedicle. So the orientation of the balloon will follow the orientation of the power curve, and it will be located exactly here on the AP and the same place on the lateral. So what we'll do is we'll switch back to the lateral, and I'm going to record this for posterity's sake. We'll take a shot there. Drop it down a bit. Oop, come on, let me, yeah. There we go. Better, okay. So that will be the final position of the balloon. And so I'll go ahead and take this out by rotating counterclockwise on the curve. And we'll take it out, remove it. And then the balloon itself is relatively new, having been released this year. And so the features on this would include an inserter, and this will lock back here, and after we deploy this, I'll pull it back to deploy it. This will allow recompression of the balloon. So once the balloon has been deployed, you can put this inserter, and this will recompress everything, and after it's used, it's pushed up and locked in place, like so. This is the device turning mechanism. So this will turn proximally. As you turn clockwise, it turns this to exactly the same angle, the tip, as the power curve. So this will actuate it, and you can straighten it out or curve by turning the proximal portion. So as I put it in, we'll monitor the course. We'll direct it exactly the same way as the power curve, and we'll watch it go in, and I will turn it to facilitate the transgression along that cavity, that canal that was created by the power curve. And what we'll see is as we push this in, it's going to be located exactly the same location as the power curve. So that's nice right there. Let's go ahead and take an AP shot to confirm, and then we'll inflate. That's a little bit over-penetrated, don't you think? So our serum's gone nuclear. All right, there we go. So exactly the same position as we were before. The marker bands are between the pedicles. You know, Phil, how could that be any more perfect? Do you know? I don't know how, is the answer. So we'll go up, and as we do this and inflate the balloon, we'll go back lateral. And this indicator has a timer. It has a PSI, not only numerical PSI, but it also has the scale over here. So this is a very nice indicator, and it has the amount of contrast, keeping in mind that this will be an 8 cc total volume balloon. So we'll watch this thing as it comes up. It's a 30 millimeter balloon. It's a big one. And this is located more medial laterally. I find this balloon to be advantageous when you're reducing vertebral fractures that primarily affect the middle and anterior portion. So this is really something that does very well. So the pressures now are in the range of 170 to 180 psi and dropping quickly. With each turn, I'm going to continue to inflate. And it's inflating exactly where it should. All right, 6 cc's, 7 cc's, and I'll trigger, and I'll pull this out. I'm going to trigger and lock it and keep the pressure on, because this will need to be consistent, steady pressure, because this is a big balloon. And we'll turn the proximal portion counterclockwise, and we're there. Okay, so cement, and this is, you bet. Yeah. So the cement is put in hydraulically by water pressure, and this is the amount of cement that goes in, keeping track. This is a cartridge that holds it, and this will be placed along, and I will advance the internal stylet just a little bit, and this is a screw locking mechanism. It will lock onto it, so we'll take a look. Got a little bit of residual contrast in there. That's okay. We will be able to tell that from the cement. And we will start injecting. We want to fill the void created by the balloon. We also want to fill into the interstices of the bone. So one of the common mistakes that we see people make is that you just fill the cavity created by the balloon and not the interstices of the bone. So it has to go into the cavity created, also locking into the medullary or cancellous bone that surrounds the balloon cavity. And so the pressures on this are in the range of about 30 to 50 psi and dropping quickly, which is perfect. Working time in the cement is more than adequate. It's about It's about 12 minutes working time, and really you can get a lot more out of that. And I've worked with this cement all the way up to about 16, 17 minutes, still going. So we see a little bit of that contrast going out, but the cement staying in. You always tell the cement, because it's viscous, the contrast is not as viscous. And at this point, I'd like to take a look AP, see how we're doing. Cement fill pattern looks great on the lateral view. Looks great in the AP view too. So always encourage everyone to fill on the lateral view. Sometimes I will fill, just put a little bit of extra cement on the AP view to see where it tracks AP. And you can see on the AP view, we're getting in and around the interstices of the bone. So it's filled the cavity of the balloon, and now it's getting into the medullary portion of the bone. And that's exactly what we want to see. And we'll continue to fill. The goal is to maximize the reduction, to fill it between the pedicles, and we want to try to get it as close to end plate as we can. Keeping in mind that this L5 is a big vertebral body. Again, the pressures are in the range of about 30 to 50 PSI, and only exceeds that whenever I really crank on it. So how beautiful is that? Fantastic. That's fantastic. Really nice. And so you get the idea, once it goes into the interstices of the bone, kind of locks it down between the pedicles. The orientation of the balloon is key for reducing most common fractures that involve the middle and anterior portion of the vertebral body. And balloon is well engineered. It's high pressure, and it is also a balloon that doesn't tend to deform. So it tends to stay exactly where you put. And so, kind of approaching the end of the procedure here. Nice cavity, nice fill, very nearly end plate to end plate. Good cement viscosity. The other characteristic, meaning the balloon tends to stay where it is called compliance. It is a low compliance balloon. High compliance is like a balloon that tends to blow up and form balloon animals. It will herniate out through the disc, will go through the end plates, go out the side. These low compliance balloons tend to stay where they're placed, high pressure, and tend to be a really excellent type of way to reduce the vertebral body in a very predictable manner. So Phil, what was the total cement volume? So this is 10 cc's in the L5. Typically the amount of cement you'll want to use is 15 to 20% of the non-compressed vertebral body volume. It varies from person to person. The greatest amount of variation has to do with the fact that a person is either male or female. And that is nice. Let's take an AP shot of that, and I'll disconnect the bone filler. I'll place the stylet back in, and we'll keep that in to avoid a tail. Man, I think we have to save that one for posterity's sake, right? We'll put that on LinkedIn later. All right, so, and this is, once you leave this in and then pull it out, and this is, again, the Arcadia balloon from Merit. And this has just been released. These are brand new tools. They've just been released this year, so this is, I've used it a number of different times, and this is a very predictable result. This is not unusual at all. So, well done. Thank you, Phil. All right, next I'll pull this out, and we will do a bilateral spine jack. I want to get one final view of that. So we save that.
You're right on track about halfway right now.
Great. Let's take a lateral shot. And we're going to do, why don't we do a spine jack at that level above at L4. Save that one. And back around, please. All right, so one of the greatest advancements in vertebral augmentation recently has been the advent of the spine jack. This is the only device has been shown to be statistically significantly better than the predicate in 36 years of vertebral augmentation. And we'll start at this level. This is L4 approach. Again, I'm using a beveled needle. The same needle system that's been sold by Stryker for a good number of years. And we'll target typically the 9 o'clock and 3 o'clock portions of the bone. And that's what we'll do in this case. That's fine, you're good. You're good. And what we really like to do is give this a very flat approach, meaning we want the skis of the jack to butt up against the end plate. Let's go lateral. Remember, before you get to violate, before you violate at all the medial wall of the pedicle, make sure you're in the posterior portion of the vertebral body. And that is exactly right. I'm going to do a little wig-wag here. Poor man's wig-wag, right? Straighten it up. Hold still, sir. Okay, there we go. So that's nice and flat, looks very good. And I'll go ahead and place this in. Stylet comes out, K-wire goes in. And at this point in time, what I like to do is I like to place the K-wire, and you can place it, most of the time, you place it just halfway in. But what I want to do is I want to demonstrate to you where the final position of the jack will be. So right up against the anterior portion, not quite there, but right about, maybe right about there. Okay, let's come back and take an AP shot of that. And what we do there, by recording that, will be the final resting position of the jack if we don't make any modifications. And I hope it's slightly off. No, it's not. So that's pretty spot on. But I might switch it around whenever we do the reamer, or just hopefully we'll be slightly off on the other side. But that is spot on. Let's go lateral. So I'll remove the cannula, and I will need a knife. There's one over here. Yep, I got it. Perfect. So just make this a little bit bigger. So the spine jack that we'll use here will be a 5.0, and it's about the size of a number 11 blade plunge incision. So we want to make it big enough so where the reamer goes through. The reamer is here, and it's not really a drill. It's shaped like a drill, but it's fluted, it's self-tapping, and it's sized appropriate. It's sized to the size of the implant, which the 5.0 means 5 millimeters. It will expand up to 17 millimeters tall. So as I put this in, I'll show you what it looks like on the fluoro. So we'll just drill this in, and this is very aggressive. And I'll pull the K-wire back a little bit to make sure, just to make sure we don't send it forward through the cortex. And we will place it all the way in the anterior portion of the vertebral body. And all of these are size matched. The distal tip of the reamer is sized to exactly the size of the spine jack. And that will be the final resting position of this side of the jack. And so what we do there is we pull it out, leave the working channel in, wire, reamer come out. the acrylic plug with the rated opaque distal tip goes in. I will plug it all the way up to the front, and this stops the bleeding, provides hemostasis for access on the other side. Let's come back around. So we'll check our position there. It'll be indicated by the acrylic and the distal tip that's rated opaque, by the acrylic plug, and so we'll access the other side. All right. Yeah, again, nice flat access. Okay. Good. And we have the other one appropriately angled, so tip and trick is on the outside of the patient. It should look, the needles should look symmetric in terms of their angulation. Not only do we look at the fluoroscope, we have to make sure that it looks okay from the outside too, using all your visual spatial tips and tricks to make you the master, to be able to use the force. All right, so that's very flat, very nice. Let's take a look lateral. And again, we'll swap out the stylet with the K-wire. Yep, that's good. So this is nice. So we're a little bit ipsilateral to this side. So I want to put the K-wire in. I want to demonstrate the fact that you can change the trajectory with the reamer. So I'm going to put the K-wire all the way out to what would be the final resting position. And let's take an AP shot of that. And I would suspect the K-wire would be a little bit more ipsilateral, the tip, than the contralateral side that we just accessed and plugged with the acrylic plunger. And it's just a little bit more ipsilateral. So what we'll do with the reamer was we'll try to medialize this a little bit. This is an additional tip and trick that you can do. So let's save that and let's go back lateral. And so the reamer goes over the top of this.
It's on screen.
And again,
Yeah, you hit the button and then you hit the
we will access this, minding the front part of the K-wire, and I will get it into the posterior third, and then I will pull the wire back. Okay, wire comes back, and as I advance, I'm going to medialize this, and you can only medialize it. Do not rocker arm this thing. Medialize it as you turn. So I'm medializing this as I'm turning, and we will have a little bit of correction as we get out to the front part of the vertebral body. I can imagine that we will be in a little bit better position and have that tip just a little bit more medialized, symmetric on the back. The tip looks fine. Let's go around and take a final AP shot of this. And these are size matched, so that will be where the final position of the 5.0 spine jack will be. And so we can compare that with this, and we are more medialized with just the movement and a little bit of a consistent, steady pressure while rotating on the reamer. All right, so this comes out, and let's go back lateral. Spine jack goes in. 5.0 spine jack, it deploys along the axis of the handle. So the patient's like, if you deploy it like this, it's going to go sideways. Deploy it like this, and here's Regan, can you hand me that other jack, please? Thank you. All right, so jack's in place. I'm going to put this one out further, just a little more than just a little bit. right there, and there. That's about good position. And before we start to deploy, we'll take one final AP shot. The butterfly handles are the deployment mechanism. The internal portion that keeps this handle attached to the working channel is controlled by the, is held on by the color knobs. So this is absolutely, so pretty quite good. All right, and we'll save that, and then let us go back lateral and we'll deploy, final position. And we're mixing the Striker HV cement in back. It's the one with the automated mixer that really is loud and disrupts our audio, so we're doing it in back. All right, so I'm gonna deploy clockwise position, and we can see the spine jack come up. And 2, 3, 4 turns there, same thing here. I'll give it live so we can watch the jack come up. There it goes. Nice. And this is 13 turns of the butterfly handle. Regan, in case you're wondering that, you probably already knew that. 13 turns. We actually counted one day just to see. And we'll fully deployment. I fully deploy these most of the time, the vast majority of times. I want to get maximum reduction. Unlike the jack in the trunk of your car, it doesn't push off the ground, it pushes off the central post, it goes up and down. And so this is full deployment. I'm going to take the pressure off, 1 turn here, and then I'm going to 10 turns for the color tube. We're going to pop this off. And same on the other side. Both off. Shot there, and let's take an AP before we fill it with cement. And that's exactly what it should look like. There's a little bit of plastic bowing deformity. This is a titanium implant, and these are appropriately bowed. And that's beautiful, right there in the middle. And we'll inject cement on both sides. Fully deployed spine jack. And let's go back lateral. Thank you, thank you. So we'll inject on one side. I'm actually going to use the internal pusher on the other side so we don't get cement coming in one side and back up the other. So as the cement comes out in the anterior portion, and we'll go up and down the jack. You can see the cement moving that way, up and down the jack. And put the collar, press the collar so it holds on. And then after it goes up and down the jack, typically it will meet in the middle. So I'll put some cement here, put some on the other side. And the Striker HV cement has a viscosity of about 250 to 300 Pascal seconds. This stuff is very viscous, purposely so, hence the name HV, right, for high viscosity. So you can see it duplicating that pattern on the other side. Very nice fill. And at this point in time, let's take an AP shot, see how we're doing. The working channel has a little pore, a hole in the anterior portion. So that's what's coming out. Very nice. A little bit more. And I'm going to fill a little bit on the anterior to see how we're transgressing medial lateral. Keeping in mind, to fill anterior, you have to do this, but make sure that you're doing this without risk of extravasating posteriorly. So do that, make sure. Good. So we're going to put a little bit more in there. Let's take it lateral. Very nice. Very good. I like the feel of that. I'll put a little bit more on the other side. And we'll use the entire contents of this. And that is all she wrote. Very nice. Center, end plate to end plate, and keep in mind you also have the support of the jacks. Jack is a titanium alloy. It can be used to support the vertebral body. And so we'll take one final AP shot, and then I'll show you how to remove these. In general, the best way to remove these is with a twist. So cement is very resistant to compression. It's a work of art. Cement is very resistant to compression. Let's go back lateral. But it is not resistant to shear. So there's holes in here. You put the K-wire through, you turn this, twist it, pull it out. And I've seen people that they just try to pull this directly out. And compression is also distraction. Cement is very resistant to this. So people panic. Start lifting the person up. All you have to do is just twist. It comes right off. So, final view. Boy, those look really nice. That's definitely going on LinkedIn later. Okay, that is it. The Striker spine jack. And I'll end right there. We'll open it up to questions and comments.
Awesome. Thank you very much. Thanks very much, Doug.
I'll do that, yeah.
Some presentations on both those spine jack and also the curved balloon from Merit and the spine jack from Striker there. Open up with any questions that people may have. The question was how long to wait for cement to cure before a patient can ambulate?
So by the time the cement is in the body, the working time for the cement that we used, the Striker HV is about 8-9 minutes. By the time the person rolls over, the cement will be hardened. The real key is to put this in a viscosity that's appropriate. And if you do that, put it in an appropriate viscosity that's kind of medium toothpaste consistency. By the time you finish the procedure, the cement will be hardened. So there's no waiting time unless you use something that has a really long working time. And there are very few of those cements remaining on the market. So functionally, when you're finished, the patient rolls over, no waiting.
Excellent. Excellent. And how do you decide when to use spine jack? Any fracture date cutoffs?
So you use the spine jack for two reasons. One is primarily for reduction, and the other one is you're trying to prevent as many adjacent level fractures as you can by realigning the vertebral body. There are two conditions. So number one, if it's an age of a fracture that can be reduced, use age. The other variable is use anatomy. So if a fracture has a cleft in it, if it's a fluid-filled or air-filled cleft, regardless of the amount of time, that fracture will be reducible. So if there's demonstrable instability, either flexion extension or by simple anatomy, or if the age of the fracture is something that should be able to be reduced, a fracture that's a week old, 12, 13 days old, still, for the most part, should be mobile. And using a spine jack in that case will give you reliably good results. Or in a case that there's anatomically an indicator or a functional indicator that vertebral fracture is not stable. So, in an arm or a leg, you can get oligotrophic, hypotrophic non-unions that don't heal and remain mobile forever. Same thing in the spine. Just be aware of that.